Behavioral medicine approaches to migraine multi-axial assessment all workup for headache evaluate frequency, intensity, duration, and disability. From a behavioral perspective, Dr. Baskin recommended considering a few more factors: adherence to therapy, stress-related issues, Columbia psychiatric disorders, and factors that transform migraine from episodic to chronic. When you talk about adherence, one of the basics of this is readiness to change, said Dr. Baskin. Is the patient motivated for treatment? That doesn't necessarily happen immediately. For example, a patient who is motivated to have an abortive agent might not be motivated to pursue prevention, lose weight, exercise, or make lifestyle changes. Over time, that might change. Dr. Baskin noted. Patient motivation may evolve with a greater understanding of the goals of treatment. Has the patient adhered to past therapy regimens? If the answer is no, then the answer will most likely be no again. Dr. Baskin said. If medication overuse was a problem, it may be again. Whenever possible, ask open-ended questions, such as, how do you decide when to take an acute medication? Dr. Baskin advised. Stress and migraine. High levels of daily stress, even daily stress that are not catastrophic, can transform migraine from episodic to chronic. Patients with depression show a greater effect of stress. Dr. Baskin said. Similarly, victims of trauma or childhood maltreatment can have more disabling headaches that may be more likely to transform into daily headaches. Many patients do not have the coping skills necessary to manage stress or recurrent headache. Dr. Baskin said. One of the goals of behavioral therapy for migraine is to increase patients' self-efficacy and give them the tools and the confidence to manage headaches and stress. Psychiatric comorbidity. Psychiatric comorbidity may complicate differential diagnosis to medication is greater in people with mood disorders and anxiety disorders. These patients may show a reduced response to pharmacologic and behavioral treatments for headache. Psychiatric comorbidities also can contribute to migraine chronification. However, if you add a small behavioral component to your headache program, patients with psychiatric comorbidities seem to respond relatively well, Dr. Baskin said. Migraineurs have a 2 to 3-fold greater prevalence of depression. There is a bidirectional relationship between migraine and depression in population studies. The relationship between migraine and depression is greater in clinic populations, in chronic migraine, and in medication overuse headache. Behavioral therapy. Our behavioral medicine program is time-limited and goal-oriented, said Dr. Baskin. We try to get people to develop self-efficacy and personal responsibility. We monitor and maximize adherence to medications and help patients to regulate their routine activities, including going to bed, getting up, and exercising on a consistent schedule. We offer biofeedback for self-regulation, relaxation and coping skills training utilizing a cognitive behavioral model, and we treat psychiatric issues, said Dr. Baskin. Many of those things can be done by clinicians who are not behavioral clinicians, he said. You do not necessarily have to refer all these people. Schedule frequent revisits for complicated or difficult patients. Do not overwhelm patients with too much information. Simplify jargon, provide written instructions, and make sure the patient understands the plan. An important component of behavioral treatment is teaching relaxation exercises, which can reduce muscle tension and autonomic arousal. There are many types of relaxation strategies. Dr. Baskin recommended breathing pacer apps, which are designed to encourage slower abdominal breathing. The goal is to gradually reduce the breathing rate to 6 breaths per minute for 5 to 10-minute practice sessions. If you can teach people diaphragmatic breathing, it takes about 30 seconds to begin the discussion, it is helpful. Dr. Baskin recommended having patients do it 3 to 5 times per day for a few minutes at a time. Cognitive behavioral therapy is another tool. It gives people an opportunity to modify distress-related thoughts and to examine their personal danger cognitions, their sense of threat, and the negative predictions that they may have. Dr. Baskin uses cognitive behavioral therapy to help patients develop an action plan based on their prescribed strategy to treat an acute migraine attack as well as manage concomitant emotional reactivity and maintain functionality in the presence of a significant headache disorder. Biofeedback relaxation training, biofeedback, thermal biofeedback, and cognitive behavioral therapy show great but modest efficacy. There is recent evidence that combining behavioral therapy with preventive pharmacologic treatment improves outcomes. The behavioral section of the American Headache Society will soon be reviewing the most recent evidence on behavioral interventions in migraine. Sleep hygiene. 3 main messages regarding sleep are to adopt a routine, consistent bedtime and wake-up time, avoid all non-sleep related activities at bedtime, and employ relaxation strategies to reduce sleep onset latency. In addition, patients should not eat or drink a lot of fluid too close to bedtime, not exercise in the evening, and avoid napping. A patient should be advised that if he or she cannot sleep, the best solution is to get out of bed, go to another room in the house, engage in a relaxing activity, and go back to bed when he or she gets tired. With these strategies, clinicians have converted chronic migraine to episodic migraine for a significant number of patients. Combination treatment of migraine and psychiatric disorder. Many doctors support the idea that one drug should treat migraine and associated conditions whenever possible. The idea is to use one agent to treat migraine and associated conditions. This strategy is simpler and may entail lower cost, fewer adverse events, and fewer potential drug interactions. It makes sense on one level, however, there's a risk of treating only one condition optimally or treating none of them optimally, Dr. Baskin said. It is important to treat both disorders the way you think they should be treated. Sometimes 2 drugs are better than one. You want to treat both conditions effectively. Thank you for watching.